So now I think I will probably move on to the last lecture of this evening. Okay, we can see my slides. See my slides. Yeah, okay, just checking. All right. So we're going to put all of this in practice, right? And look at case-based discussion, how we're going to apply all these lectures in a patient that we are going to see in real life. So hopefully you'll be more confident in primary care even without spirometry, because I think Nida had mentioned that, was it Maza? I think it's Azila had mentioned that you don't necessarily have to have a spirometry to diagnose asthma. We hope that you would be able to be confident in starting as well as adjusting the controller therapy with whatever medications available to you. You want to be able to recognize exacerbations early, safely, and know when to refer. And I think probably, hopefully, if you've taken Lian's advice in terms of looking at the videos and empowering yourself, you'll be able to teach patients the correct inhaler technique and self-management. And the endpoint would be that you will be able to use the document that is known as the Malaysian Asthma CPG to make you more comfortable in terms of managing asthma patients in your care. So I think we cannot run away from the fact that in primary care, majority of patients could be underdiagnosed. They have asthma, but they do not come forward with forthcoming symptoms. And because they are not diagnosed, they are not treated. And a lot of them are managed with SABA only, right? So these are the points that we want to move away from. So our CPG, she emphasizes that try to move away from SABA monotherapy, and also all asthmatic patients should receive some form of treatment that controls inhaled corticosteroids. So we're just going to go through a case presentation. This is Miss S.A. She's a 28-year-old woman. She works in a pharmacy, sorry. She's got a 5-month history of recurrent cough and intermittent wheeze. So she says the cough makes it difficult for her to sleep. It's okay during the day. She coughs when she does. And she's got 1 cat for the last 10 years, right? So what is your diagnosis? Again, if we've gone through the mornings, the early afternoon session, we realize that history plays a huge role. And the history looks like there is chronic cough because it's 5 months. It appears to be intermittent, and it appears to have some diurnal variation, and it appears to have some triggers. Yeah, okay. So typical clinical history, we would agree on that. Physical examination, you probably want to see whether there is any wheeze, whether the patient's breathless at that point, whether she's got any cough. You want to have some evidence of variability, whether it be spirometry with the bronchodilator responsiveness test or a PEFR diurnal variation. So spirometry preferred, but it's not mandatory. So we go back to her. You can see that she's got all of this. Now, I probably just want to say something about the cat, right? It is unlikely that the cat is the cause of the problem, and I don't think that we should be very fast to blame the cat. Okay, so before you ask the patient to remove the cat from her life, you should actually go through all the other triggers, because she had the cat for 10 years and she only had the cough for 5 months. So if the spirometry is not available, and I think from the questions that we have actually, the initial questions coming in would be how would we recommend and make sure that spirometry is actually used? A lot of it is actually awareness and also availability and also knowing what to do when you have a spirometry. So I've actually mentioned in the Q&A that we have a spirometry certification course, right? So assuming that you don't have the spirometry, the CPG document actually allows you to do what is known as the peak flow variability, meaning that you measure the patient's peak flow twice a day for 2 weeks, and we calculate the variability. If the variability is 20% and more, this shows that the airway is very unstable, right? You can also use a trial of treatment, meaning that you give the patient a trial of inhaled corticosteroids for a short period of time and get the patient to come back to you and see what the response is like. So either you, for the lady, she's got chronic cough, you can give her a trial of ICS and you see whether she improves. So if her nighttime symptoms disappear and she actually is more stable when she doesn't actually have any cough, then this is actually proof of concept. Okay, so I think the main thing I would like to reiterate would be that you do not delay treatment. For example, you tell the patient, oh, you don't have peak flow variability, you come back after 2 weeks, I can't give you any medication. First, you need to do this before we can actually diagnose asthma. No, we try to move away from that. So you should educate the patient on the correct way of using the peak expiratory flow meter, and then you can tell the patient how to use it, where you actually use it morning and night in a seated position, same meter to reduce the bias, also relatively same time of the day, right? So you take 3 readings and you record the highest at each time. So the PEFR, it's known as a diurnal PF variability, where you take the days highest minus the days lowest over the mean of the days highest and lowest, and you multiply by 100. So for example, if your highest that day is 500, your lowest that day is 400, the mean of that day would be 500 plus 400 divided by 2, and you divide this and you multiply by 100, and that will give you 22.2. So this lovely calculation will have to be the average daily variability over 1 to 2 weeks for diagnosis. So you cannot just calculate for one day and say it's 22% you have asthma and this is it. It's not negotiable, right? So we do know that your airways, we need to prove that your airways are variable over a period of time, not just in one single moment in time. So if you, I think our document is available on the internet, and if you have a look at the Appendix 3, which is on page 69, the members of the CPG have worked hard to actually give you this example of calculation for you to be comfortable enough should you choose the PEF monitoring for your patient. So I think the take-home message would be that asthma diagnosis is a clinical one, and spirometry, while it supports the diagnosis, it should not delay the treatment for the patient. So Mr. S.A. is a known asthmatic. She's only using inhaler salbutamol daily, which is a big no-no in this day and age, especially, on the 11th of April 2026. You should not have any patients who are just on SABA therapy. I think the reason is because asthma, if you remember Dr. Maza's slides, remember I said it's a bit boring, but incredibly important. The inflammation is the backbone. So this salbutamol that you puff is not going to do anything for the inflammation. Therefore, you're just going to not treat the problem, right? So you can have a look at her. You can see that she's not on the appropriate treatment. She's not on any ICS treatment. Her symptoms, therefore, are about 3 to 4 times per week with coughing, and she's got nighttime symptoms. So how would you treat this patient? Do you have enough to treat? Yeah. Do you need to do the PFR variability? Not necessarily. You can actually give a trial of treatment, right? So let's see the trial of treatment. So number one, she needs whatever she needs to be given, that SABA alone. So some people actually say, oh, does it mean that we throw the SABA out completely? No. The key here is monotherapy. We're not saying that SABA is bad. We're just saying that SABA cannot be used alone. You should team it up with ICS. So the treatment options based on the CPG algorithm would be either your PRN ICS formoterol, or a low dose ICS with PRN SABA, or low dose ICS with PRN ICS SABA, or just a PRN ICS SABA. So notice there is no SABA alone. Do you see? SABA alone doesn't count. Whatever is happening here, there's always some steroids, right? Formoterol, low dose ICS, PRN ICS, right? So again, you're probably going to ask in the chat group, so I'll save you the trouble. Which one to be used? Okay. So the choice depends on availability. It also depends on the patient's preference. And because some of these inhalers come in different devices, so if you take into consideration what Leanne has actually just brought us through, the device makes a difference, right? So you can see that, for example, you have a very nice Porsche, but a very old man, so it doesn't really suit the person. Same thing, right? So the old man needs to be in a Kanchil, when the young person needs to be in a Porsche. So ability to use the correct device. If the device suits the patient, that is the correct device for the patient. So in the earlier patient, the patient with the CAT and the chronic cough, a practical primary care prescription would be budesonide, which is ICS, 200 mics BD with salbutamol PRN. You can actually use that. Or if you want to use, you can use PRN ICS formoterol. So again, availability, patient preference, ability to use the device, right? And I think really a lot of times we get swayed with the patient's preference, right? So if the patient likes it, the patient needs to be able to use it, right? If the patient can use it, then this is the correct thing. So I think you have to probably, how do we know that the patient can use it? Is by actually looking at the videos online and then having some dummies available in the clinic to test the patient's ability. And if the patient can use it in front of you or is comfortable with that, then that is the correct way of choosing it. So this is algorithm 2. I think you've seen it already earlier, but I think probably what I want to tell you would be that in asthma, it's not a one way, like up, up and away, right? Forever. So a lot of people say, I keep adding on and you forget to step down. So let's just have a look. Even the name of the algorithm tells us that if you can, what goes up can come down. There is a step up and step down option in the management of stable asthma. So once that patient has stabilized, so for example, if a patient is on high dose ICS lama, right? You already given triple therapy, for example, and you're going to phenotype the patient. You're going to say, oh, I think this patient actually needs biologics. But when you review the patient becomes suddenly much better, then you do not have to go to biologics. You can actually then drop it to high dose ICS LABA, and while you actually target the triggers in the patient, if the patient continues to improve when you next review, you can actually cut back the dose of ICS, high dose ICS LABA to medium dose ICS LABA. When the patient then sees you, it's compliant to treatment, technique is much better, you consider stepping down. Now, at this point, let's say medium dose ICS LABA and the patient is symptomatic, right? Before you consider stepping up, take a look, ask the patient whether the patient is using it and make sure that the patient is using it correctly. If the patient is not using it, there's not much point increasing to high dose. The patient needs to stick to medium dose ICS LABA and continue to use it. So, patient was started on budesonide inhaler, 200 mics BD and salbutamol PRN. Comes back 1 month later, still symptomatic, unhappy with your treatment. Yeah, there are a lot of patients like that. I think, yeah, I'm sure you have patients who are unhappy with you. So what's the next step? I suppose I've mentioned it earlier. Next step is make sure that she's using the correct inhaler, make sure that her technique is correct, she's adherent. Also make sure that she doesn't have any new problems, any new triggers. And perhaps you want to take time to actually get history to see whether this is indeed asthma or not, right? Assess your adherence, the inhaler technique, risk factors, and if all of this is addressed, right, then you can step up to ICS LABA. Right? So this is the step up, step down that I've actually mentioned earlier. So asthma exacerbation in primary care, I think Dr. Nida mentioned in great detail. I was, listening. I think if you had paid attention, then this slide can just go on to the next one. But okay, we're going to assume that we want some reinforcement, right? So you can have a look. Her slides are better because she did Gemini, right? So I haven't actually moved on to Gemini. So this is snapshot of the asthma CPG. So she's severely breathless. She's unable to complete sentences, and the SpO2 is 92. Remember, we said 94. So she's in asthma exacerbation. What do you want to give? You want to give your SABA, and you get 20 minutes, and then you assess up to a full hour. You want to start her on prednisolone, and her sets are 92%. You're going to slap some oxygen in her to keep her saturation 94%, and you're going to give systemic corticosteroids, right? So this is exactly what she has mentioned, and now it's come to fruition in this patient who actually presents with exacerbation. So I think probably you want to worry about when to refer. When your patient's symptoms are severe, so medicines and art, and all of you are doctors, right? So you know when the patient is not responding to treatment. You would have seen enough patients to know that at this point they would probably have improved, right? And you look at the patient overall. So let's say her saturation improves, but she begins to tire out, right? So that again, you don't look at one single parameter. It means that she's not really improving. So you want to refer. Any life-threatening features that the patient has in terms of if you have ABG, the saturation, whether she becomes drowsy, whether she becomes more tachypneic, then you want to refer the patient. So I think that your inhaler technique, it's an important point because the majority of patients need to have some form of remedial when they come to you in clinic. So never assume that the patient's got good inhaler technique. I suggest that you look at the YouTube videos. What I normally do in clinic is I open up the videos and I show the patient, and I also open up the patient's phone to actually send the link to the patient's phone so that they can actually continue to look at the inhaler technique when they go back home, right? Because you can see that there's this waning effect. You teach the patient, they go out the room, the knowledge goes down. By the time they take a grab back, the knowledge goes down even more. By the time they go back home, they might have forgotten what you have actually taught them. So just remember the asthma is a clinical diagnosis. ICS is important. Do not use SABA monotherapy, and you want to assess the control and also your adherence before you slap the patient with a higher dose ICS LABA. Um, Treat exacerbations early. Certainly, you must use systemic steroids, and whatever is, do not go away from patient education and inhaler technique. Okay,